All right, so let's take a few questions. We'll start with the PCCs. Questions. See, maybe one, do you believe that implementation of the model will improve health in your community? Yes, no kind of responses.
We were pretty consistent saying, yes, we definitely thought that it would, and had all kinds of different reasons
Okay.
why it was, how it was going to work.
All right. Awesome. And barriers to implementation, PCC perspective?
Money and finding people to hire.
Absolutely. Finding people that are trained and ready to do this job is a huge challenge right now. So I would say get your infrastructure created, hire somebody, and if you let me know, I can send you a job description, interview questions, and some guidelines for who to hire. And then get training. Get training, because people can be trained to do this job. A wide variety of people can be trained. What's unclear to you about this model at this point? What questions do you want our experts to answer?
We were wondering about how it was going to impact the flow of operations. That came from our discussions.
Okay. All right, so this is kind of just in a nutshell. It should support your flow. It shouldn't interfere. So one of the ways to kind of work with that is in the morning, the BHC can either attend the huddles in the clinic, anticipating the patients that are coming in that need to have behavioral health consultant services, and then plan to return at those times to pick up the patient. Or they can simply scrub schedules and anticipate when they might be helpful and show up there. The PCC should be a team, and other team members, the EMA, whoever's kind of working with them, should be able to say, this PCC is running behind. Why don't you see this patient before so that they can catch up? And they shorten down the appointment time. So it really, BHC services are designed to support flow rather than interfere. They're pretty flexibly trained, so if there's limited time, they can shorten their visit. If there's limited space, they work with that too. They do have, billing forms and counters would be generated for all their visits, so they would check in. Many of their visits are same-day visits, so they should be trained by the system to walk people in from the PCC schedule into their schedule, so nobody is needed to do that for them. That's pretty simple, straightforward. Did that help? Yeah. The big thing in terms of flow is when they're doing groups. And I used to do chronic pain classes that had, I'd see 60 people in one day. And so I had to work with the front office, so that on coming up with a system that worked in terms of getting these people out of the waiting room basically quickly, and then out of the pharmacy quickly.
Oh, just to add to that, one of the things that we added
one of the things that we added that was a tough agreement, but we got to it, and now that we're doing it, it's pretty easy, is that when a behaviorist is in with somebody and there's a crisis, you can knock. And they, so they warn all their ongoing patients, that I may be interrupted, and it's different than it is in an outpatient mental health facility, but it works. And one of the things that we're going to augment is give them pagers. We tried cell phones, and then texting, but that doesn't work as well as a pager going off, and because there's a variety of things that cell phones get used for. So the pager was something that we're going to sample.
Okay. And we showed a video early this morning about just a PCC knocking on a BHC's door just meet and greet somebody with sleep problems. So, I mean, it's like they can knock on the door anytime.
Question I heard actually from all three physician PCP groups was, how does this model kind of relate to specialized mental health care? So when does it turn from one to another? It seems to be that that was a pretty common source of confusion. The best way to think about this is the same continuum of care that exists between primary care and specialty medicine, right? So over the last decade, the scope of primary care practice has expanded exponentially, but there's still sort of a point where you start to say, I'm out of my scope with this person with cardiovascular disease or childhood asthma, and I need to have a specialist take a look, right? So what is missing in the mental health system, and what has been missing since its inception, is there was no primary care version of mental health. So you basically have gone from primary care and only through one door into a specialty system. So the way to think about this is we're building the primary care version of mental health, right? And so a lot of the questions about how far can you manage people, if you take that approach, have never been answered. But I can tell you this, when we did the first clinical trial of major depression in primary care, our behavioral health colleagues were telling us there were going to be suicides all over Seattle, that this was malpractice, that we should be delicensed. And what it turned out to show is that not only was the treatment as effective as in the specialty sector, it cost 1/4 of the amount. And if you look at the developing literature over the years, one problem after another that previously people thought could only be treated in specialized mental health services turns out to be treatable in a highly condensed, abbreviated primary care. In the U.S. Air Force, they're treating post-traumatic stress disorder, combat-related post-traumatic stress disorder, in the PCBH model. Those are conditions that 5 years ago people would have said it's a no-brainer, that person needs 16, 20 sessions. So what we're doing is we're finding out what is the scope of practice that's actually going to work in primary mental health care. And we're only 55 years behind the physical health care system, which has been working out that same problem.
Good point. All right. Take this side.
Do you guys know of any clinics that are utilizing both models in the same clinic? So they have some behavioral health consultants that are just doing the brief model, and then they have maybe one or two clinicians who are doing traditional mental health that they can refer to within the same clinic.
They have that in the Air Force, but mental health, it may be next door. So it's a referral. As they've pushed on this, what they've done is reassign more and more folks into primary care, behavioral health, and shrink down mental health. That's been the direction.
The Virginia Garcia clinics do it.
Where is that?
They're around the Portland area.
Okay, more, behavioral health folks believe the implementation of the model will improve health. Community consult on that. Barriers?
Buy-in
Okay.
from administration, from staff.
And patients. And patients.
But that's from the PCC side, getting buy-in from patients?
Just trying to figure out how to communicate their role and not have it be threatening to the patient.
Yes, yes. And I tell you, and that's a tough thing to do, and it falls on the PCC over and over again. I survey people as part of training. You know, I have you'll see it this afternoon, referral barriers questionnaire, and one of the items is worry about alienating the patient by recommending a visit with a BHC. And it's hard. It's hard. There's some real, meaty issues in that.
And I
And
think part of the buy-in problem also is reimbursement, issue with reimbursement.
Okay. So feeling like my service is worth something because it is compensated at a,
Yeah, how are we gonna bill for this, and is it gonna cover the cost?
yeah, okay.
Patricia, can you repeat some of the comments? I'm having a hard time hearing.
Yes, I will.
You don't have to backtrack.
Okay. How far back? Okay, I'll start. Okay. How about anything unclear about the model? I was talking with the behavioral health folks and telling them a little bit about their training that's coming up over the next 4 days, and I think people were pretty excited about it, felt it was going to be pretty detailed and valuable. So I'm looking forward to that. And more from folks in the middle, what do you believe that implementation will improve the healthy community?
I just want to ask you, and this was a question from the administrative perspective, is who, how should develop, manage these care pathways? What's the workflow for that process?
Okay. The workflow would be typically your behavioral health consultant would do something like survey the PCCs and RN in your clinic, and I have surveys y'all can use to find out what your primary concerns are in terms of developing a pathway. So it's driven by PCCs and RNs, understanding of your population, who you're serving, the impact they have on the clinic, the fact that outcomes are not great for them. And then you prioritize, you choose one pathway, and you look at, well, okay, what are we doing? What's the evidence? And then you go forward. So it can be as small in terms of workflow, as small as the BHC and one doctor and one clinic manager that meet 3 or 4 times and plan a pilot. And you get the bugs out in a pilot. And then other people are starting to hear about it by then. And if it's working, if you really are starting to improve care, you know, people notice and they say, when are we going to get this? How are we going to get this started? That's the flow.
So you're just picking one pathway to start with and doing one at a time, or are you implementing 10 at a time?
I would, when you do the first one, I would do one at a time. So people get the idea that the BHC is a resource that can be used to improve, because you're teaching about how to build a pathway and what a pathway is. So I'd start with one and succeed with that. And once you've got kind of that template, that pattern, that process, you know, understood by the group, it's a lot easier to come in with the next one and the next one. And it can be definitely linked in with your QI committee.
So we have a lot more questions on here too. To go through.
You got more questions? Yeah.
In reality, when you do care pathways, like Patty was saying, it normally will start with you and me being the BHC and a champion that's a service provider. In our clinic, for example, we have a chronic pain program, and we started it by me just suggesting to this one team that, hey, why don't we have everybody who's under a pain contract on the team here come to a class once a month, and if they show up, we're going to refill their narcotics, and if they don't show up, we're not going to refill their narcotics. And we're going to start changing the language about, you know, that narcotics haven't really been shown to help long-term restoration in chronic pain, but behavioral, cognitive behavioral skills have, and so we're not going to do substandard medicine here. So it's just a requirement. And then the word started getting out that this was saving people huge amounts of grief with these unmanaged drug-seeking requests. We were weeding people out really who weren't legitimately trying to do something about their pain. They wouldn't show up for the class despite repeated warnings, and then we would taper. But over time, it became an organizational policy, right? So basically it went from an idea to the pathway was really an organizational policy statement. So our organizational policy statement is 15 pages long, and it lays out every detail of the instruments that everybody will use, that there's a single pane contract that everybody will use. There's an opioid risk assessment protocol all the way down. There's in our EMR, there's a specific template you shall use. I mean, there's a lot of shalls. And at the back end is this little simple class, which was the first thing that happened. But it triggered everything sort of retroactively all the way up the pipeline so that we could get consistency.
Yeah, you don't have to have it all tied up when you start. The best way is with a pilot. And that's a very complex kind of pathway moved into policy, but you can have things very simple, like every initial diagnosis of diabetes visit will result in the same day referral to the BHC. That's a pathway. You know, you try it for a while with 1 or 2 PCCs, nurses, and then you say, hey, this is working pretty good, and spread it.